All right. Well, good afternoon, everyone on the East Coast, and those on the West Coast, happy early morning to you. Brandon Garrett, the National Minority Equality Forum. We're at part 2 of a 3-part series on COVID. Last week, we talked to 2020 NMQF honoree, under 40 honoree, Dr. Knighton on prevention. This week, we're talking with both an inaugural class member, Dr. Gatson, and the 2017, along with me and myself, awardee Dr. Gupta, about COVID, what does it look like? And so I'm super excited about the show. We realize that we really need to constantly educate folks about this, and I'm glad to have such amazing physicians and healthcare practitioners leading the charge. So without further ado, I'm gonna turn it over to the always great Mia Keys, and hopefully we have a good discussion. Thanks.
Oh, I know we will, Brandon, and thank you so much, NMQF, for again just bringing the really very innovative word and in a way that's not only receivable but also very easily translatable. And also we just have a really good time here on this platform. So I echo Brandon's words. Thank you to Dr. Gatson and also to Dr. Gupta for joining us today to talk and to extend our conversation on COVID-19. As was mentioned earlier, last week we had a conversation on prevention, and Dr. Knighton brought with her some really very vivid infographics, straightforward infographics for those who are just wanting to know the proper ways to mask up, to physically distance, to wash one's hands, and just overall live in a healthy way during this really very unusual time in which we're living. And so we're excited today that you two are going to help us to extend that conversation. I just want to tell you all a little bit about our speakers for the day, our panelists. So we have Dr. Vin Gupta, who joins us as a affiliate assistant professor over in the University of Washington at the Health Metrics Sciences at the Institute for Health Metrics and Evaluation. And he is by training a pulmonary and critical care physician, and overall has just been caring for critically ill COVID-19 patients since the early days of the outbreak. And if you recall, the earlier outbreak began in Seattle, in Washington, where he is. So we're really excited that he brings his level of expertise today, not just with respect to COVID, but overall his background in public health is focused on epidemic preparedness, as he has done work with the CDC with respect to emerging infections and their program, with the World Bank, with work even in the CDC in China, through the Pentagon, and of course, if you are a regular MSNBC or NBC News watcher and fan, you've likely caught him on a couple of series. So welcome, Dr. Gupta. We're glad that you're here today. We also have with us Dr. Natasha Gatson, who is currently the director of the Neuro-Oncology division and at Geisinger Health in PA, outside of a very rural area. And so we're really excited that she's able to bring her expertise as someone coming from the largest rural health system in the nation, which has been around for well over a century at this point. And so we're really excited that she's going to help us to concentrate the idea of COVID in a rural population, and especially when we're talking about inequities and disparities, she's able to bring that perspective as the chair of the Center for Excellence and Health Equity over there at the group. So we're excited for you, Dr. Gatson. In terms of your background, what I also find really exciting is that as a neuro-oncologist, you're also going to talk to us about the overlap of COVID-19 and cancer, and the ways in which that impacts your patient's speech, thought, movement, and so on and so forth. And so we're really excited about that level of conversation, and overall just helping us to keep in mind that when we're talking about pandemics, we're also talking about justice. We're also talking about what anti-racism looks like in medicine. And so thank you so much again for you both being here. So I'm not sure if you were able to catch last week's episode, but we did talk about prevention, and more specifically, we talked about prevention do's and don'ts, right? In terms of wearing one's mask properly over one's nose and mouth, and not necessarily bringing it down and resting it on the neck when you're eating, and then just lifting it back up, because the exposed area of one's neck is also prime area for congregating a virus and such like that. And so if you just pull the mask down and then pull it back up while you're eating, you're just going to put it back in your mouth. So I'm hoping between the two of you, you can just reiterate proper prevention techniques for us.
Thank you. So I'll start. I think the basics, really are still the most powerful ways that we can approach prevention, wearing the mask. And in some cases, a lot of people have gotten into wearing some of the cloth masks. As a healthcare professional who's in the hospital at least 60% of my day and week, I have to wear both the surgical mask underneath, and then I wear a more of a stylish cloth mask, understanding that the cloth mask is more for style and, design. It really, is not the most, the best approach for me as a healthcare professional. So I double mask that way. Washing your hands, avoiding touching your face. It's something that we've had to really sort of get very comfortable with. And even when I've been doing Zoom meetings, I feel like sometimes I see people in the Zoom meeting touching their face quite a bit. And it's something that we're now more conscious about, the physical distancing. And as a healthcare professional, the word social distancing, it's not necessarily the most appropriate way to think about it. It's a physical distance that we need, and that social distance we necessarily don't need. Like you and I are being social now, and we're doing the virtual, discussions, and so that's not necessarily the proper word. I think the fact that those things are gold standards, those things are principles that we cannot stray away from, and making sure that we do it again as healthcare professionals or parents and people that look up to us. If we're role models, we need to really be certain that we're doing it properly and we're doing it frequently.
Dr. Gatson, I really appreciate you bringing that element about face touching. As a glasses wearer, I am so very conscious of the fact that I'm constantly doing like this or I'm doing like this, but I'm inadvertently touching my face, right? And so you can't see it, but I'm now sitting on my hands every time I put my hands down, because it is very difficult for me to do so unconsciously just yet. It's not a built-in habit. And so really what we're talking about when we're talking about prevention, we're talking about behavior change, but we're talking about mindful habits. And so I think for those of us in the audience who are building in mindfulness habits and new habits during this time of COVID, we can extend grace to ourselves, but also hold ourselves accountable for practicing the right prevention techniques to keep ourselves healthy and our family and our neighbors healthy. So thank you for that. Dr. Gupta, have you any opening words or anything you'd like to share in addition to what Dr. Gatson mentioned?
Yeah, thank you for the opportunity, and it's great to be here again with the forum and just to be with all of you to talk about these important issues. To try to highlight some different issues and layer on top of what was just said. I get asked all the time, what about face shields in addition to cloth masks, and what's the role for eye protection, and can face shields be substitutive? Because people don't like wearing a mask, or if you're a teacher, I got a lot of questions from teachers. Can we wear a face shield because I'm about to go back to school? And because certain states, despite best recommendations, are still moving ahead with school reopenings. And we know elementary school students don't like to see their teachers and their parents in masks. And so can face shields be substitutive? And the answer here is we don't know. We just simply don't know. As Dr. Gatson and I, on the inpatient side, we wear face shields in addition to masks. But are face shields completely substituted? The answer is probably not. The recommendation in places like California is you can actually wear a cloth mask in addition to a face shield. And we think that the face shield doesn't entirely create this perfect seal around your neck where droplets can still come through. So it's a partial solution, but it's not a comprehensive solution. So that's one. Two, one question I get is, how often, Doc, do you need to wash the cloth mask, or how often do you got to sterilize them? And can I just put it on top of my car windshield if I get that question from folks in Texas or Florida? And on that piece, it's important to note that the N95. Actually, I have one right here in front of me from just clinical service. The N95 mask, when I'm in the ICU, for example, to reuse this guy, it has to get exposed to temperatures that are greater than 212 degrees Fahrenheit. And I'm not saying we've determined what the optimal temperature is to sterilize a mask. We just don't know. But what we do know is that COVID-19 doesn't like temperatures we think above 120 degrees. Does it operate between 100 and 120 degrees? Well, we thought it didn't back in April. If you heard all the pronouncements that summer heat was going to bring a reprieve, that hasn't proven to be true. And India, Brazil, and other examples have shown COVID-19 is not sparing places that are really hot near the equator. But temperatures above 120 degrees, perhaps. The safest way to clean your cloth mask is to launder it to the extent that you can. Put it in the washer, air dry it if you have nice sun exposure. That's going to be better than just assuming you're going to get enough UV radiation with the mask sitting in the car. So I'd urge people to wash their masks.
Definitely. And I've also heard people saying things that, in addition to putting it on their car windows, people say I put my mask in the oven and all of these other things. We are not necessarily saying go and bake your mask, right? I just want to be very clear.
We're not. I urge you not to do any type of heat sterilization at home, and just go ahead and throw the mask, if you have a cloth mask, in with your laundry, and consider air drying it so you don't have shrinkage and potential issues with fit. Because one issue, again, as we talk about school reopenings, as we acknowledge that COVID-19 has airborne properties, a terminology that I think is so confusing. I don't know, I won't speak for Dr. Gatson, but I'll say that I have to be reminded what airborne transmission of a virus is with signs in an ICU versus droplet. And yet we're talking, using these terms all the time in public discourse. It's confusing. What we do know is that you need a mask, and ideally you need a high quality, well-fitting mask to really protect you from COVID-19 in internal spaces like restaurants, classrooms. So fit is key. A good fitting, thick cloth mask is absolutely vital. So if you have something that works well now, don't throw it in the dryer, because then you risk it shrinking and causing fit issues. So put it in the washer, air dry it if you can.
And can you both tell us how often, so at the top of COVID, one of the main things that we were concerned, I'm with the American Medical Association, one of the main things we were concerned about is getting PPE, personal protective equipment, to all of our first liners, right? And the narrative we kept getting is people are reusing their masks, right? And so it's a similar tenor now with some people in just regular day-to-day. Can you reuse your masks, your N95 masks? And if so, how often? And if not, can you just spray it to sanitize it? And if so, what with?
Yeah, I'll start, and I'll let Dr. Gupta finish, because he's probably more likely had to deal with the issue of reduced access to PPE, and that's that personal protective equipment. What I was experiencing a lot in the hospital was when they had the initial shortage of those N95 masks, they were doling them out in certain quantities, maybe 3 per physician, and they were requesting that we resubmit those so that they could be sterilized and then reused. I had a lot of questions initially about what is the breakdown of that particular product after it's been re-sterilized and used multiple times. They limited to 2 or 3 uses after re-sterilization. I personally never really felt comfortable with that. That's over with now. We now have a nice stock of those, but you're more responsible in how we use them. As far as people, answering that same question to make it digestible for our lay persons that are watching, washing the mask, as Dr. Gupta mentioned, just in your laundry. The confusion about high temperatures may have come from when he talked a little bit about how we sterilize those, and that really applies to us in the hospital. But for lay people, for people just in the general public in our communities, washing that in the laundry is really the temperature and the exposure to water, and that is what we're hoping helps. I have to be honest that we are not absolutely certain about this. So if it were just the physical distancing, washing your hand and wearing a mask, honestly, if everybody just did those things, we would have a reduction. But would it stop the virus? The answer to that is very likely no. These are things that just minimize it. It makes it safer. So I think those are important, pieces to kind of consider there. And when you talk about rewashing, another quick point I wanted to make was I thought about this when Dr. Gupta said you need a good thick cloth mask. I saw one experiment done where they held a match up in front of the mask, and someone was wearing really something that was just very stylish, and it was just very porous, and air just penetrates right through it, just like a droplet could. And they held a match in front of the two masks, and the mask that was secure, the person couldn't blow the mask out, but the person who had a very thin mask blew the match right out. And I think, you know, we need to be sure that we're using simple ways that people can digest and understand how to test the quality, you know, of your mask.
I think off camera, I'm going to go and do that and see if I can blow out a candle. This is what I do want the audience to do, and maybe we can help each other, because accountability is a major part of prevention, right? So if I touch my face, I do want you all to make a notch or mark it in the chat or something like that. Just count how many times before the end of the call I might happen to touch my face, because I think that will be helpful. I'm wondering, before we move on to the next line of questioning, if you can talk to us about the actual purpose of the face shield. Is the face shield to protect us from others in the same way the mask does, and I mean specifically the mask the face shield by itself? Although we've already heard what you said, Dr. Gupta, to not wear the face mask by itself, right? So if you can talk to us a little bit about that. And then also for our audience, if you have questions, please make sure to put your questions in the question and answer box and not the chat, because I can't see the chat. It's distracting to me when we're talking. But go ahead.
So I'll say my experience with the face shield is the following. It is intended to prevent so-called exposure to droplets. And so what is a droplet? We keep using this term. It's these big mucus balls that you can't see, but we call it droplets. They're greater than 5 to 10 microns, which is vastly smaller just than even a millimeter in size and in diameter. Envision larger, though microscopic, mucus balls that contain COVID-19 that get emitted just with normal speak, that get emitted in large quantities if you're yelling, if you're singing, or if you're coughing. And so the idea here is a shield is like plexiglass. So if you've been at a grocery store, you'll see now a lot of grocery stores have plexiglass between you and a cashier. That's the idea of it. It's meant to mitigate exposure to those large droplets, so to speak. The complication here is now we're talking about airborne transmission of COVID-19. What does that mean? And any time somebody coughs or speaks and they're infected with the virus, they release these large droplets and they release small droplets, we think at least. And those small droplets are airborne droplets. And what's the difference? It's just the size. So if it's less than 5 microns, don't worry about the actual number, but if it's really small, we consider them airborne droplets, or that the virus is airborne, meaning these little, really tiny, small droplets of COVID-19 can spread for many feet and can persist in the air for many hours. And so that's the idea between a virus that's airborne versus a virus that's purely droplet transmission, which is these big mucus balls that usually fall to the ground within a 6-foot radius of the individual that's coughing or talking that's infected. The face shield will protect against droplet transmission. It is not going to be 100% foolproof against to protect you from those small droplets, a virus that is so-called airborne. So let's talk about small droplets, large droplets. Let's remove airborne from our terminology. Face shields protect against large droplets are not going to be great against those small droplets, and that's why you need a mask. And the better the mask, the better fitting the mask is, the better the protection. And I can rabbit hole here for 20 minutes, so I'm going to stop there, but let me know if there's anything I can clarify.
That was helpful. And I have just one more question with this line. Talk to us about the differences between masks, KN95 versus N95. Now, we do know that for the most part, we want to be mindful of making sure that there's enough for providers, although to Dr. Gatson's earlier point, we're not in the same boat as we were at the top of COVID with respect to PPE access. So talk to us about that.
I'm happy to take it. So an N95 mask, the difference in what is an N95 mask? It filters 95% of the particles out there at a very basic 30,000 foot level. 95% of the ambient particles, pollutants, and COVID-19 droplets that are in the air, you think you're going to get protected from if you have a well-fitting, appropriately fitting N95 mask. I cannot emphasize that enough. Dr. Gatson and I have to get fitted for this. It's a 10 to 15 minute process, and it requires rigor. It actually requires significant, I fail the test all the time because I just don't do it properly. And so, so let me clarify and emphasize the importance of fitting. A KN95 mask has been developed to approximate the efficacy of an N95 mask, but it is not certified for use in an inpatient setting. So I can't wear a KN95 mask, which was largely developed from manufacturers in China, in substitution for an N95 mask. Our essential frontline workers in grocery stores and other essential organizations, are they purchasing it for their employees? Yes. Is the efficacy almost similar or essentially the same as an N95 mask? We think so, presuming that they've gone through quality standards and appropriate accountability testing. That was the big issue. Back in March, April, a bunch of KN95 masks came in from overseas, and we had issues with their quality. In some cases, they were 30% as effective as an N95 mask. So if we're sourcing N95-like masks elsewhere, we have to make sure that they're safe and effective, and that was one of the big lapses from our federal response. We got all this PPE that was not good enough. So, but now we think KN95 masks might be as good as an N95 mask, but that are not appropriate or certified for inpatient use. And then there's surgical masks like this, for example, that have a very different purpose, will protect largely against the large droplets that you might get exposed to in a grocery store setting from somebody infected with COVID-19 who's coughing. So if you're close to them within a 6-foot radius, the idea here is that something like this or a thick cloth mask will protect you and will protect another individual if you're the one emitting those droplets. But there's going to be, but of course, there's going to be some limitations to the efficacy of this versus this, and we just have to accept that. I'll pause there.
Yeah, and I'll say one thing too, especially because this kind of talk can get a little stressful for everybody, because how many of us have access to all the different types of masks, and since when do we know when to apply those? I'll just say in general, our communities, or people in our communities, from day to day, our patients walking around, we wear generally the cloth masks, and a lot of us have access to just order the surgical mask. That's the base. They call them surgical, but Dr. Gupta, I wanted to defer to him because he had the examples. If you could hold that surgical mask up, that's really just the very basic, mask. This one is, I don't encourage people to frequently reuse that one. And then the one that's the N95, that is, Dr. Gupta, if you could one more time for us. Yeah, that one, you're pretty much going to see that on people in the hospital. Those are for healthcare workers that are really working in the trenches, with those patients that are ill. And on top of that, he would add a face mask, a face shield, to that.
Well, we've certainly been able to talk much about masks and about prevention tactics overall. So thank you so very much for bearing with us with our questions. I want to talk about individual level behaviors and what risks, puts people at risks beyond improper preventative practice, right? And I want to be careful with this question because the National Minority Quality Forum is really very much focused on not necessarily individual level risk behaviors when it comes to COVID. We really want to be careful not to blame shift and say people get COVID because, although there are some bad actors, right? We mostly focus on the structural and upstream and the social determinants of what makes certain communities more vulnerable than others. But to the extent that we are able to practice prevention individually, do you see certain habits that are common amongst your COVID-19 positive patients, such that someone else who's negative can learn from those quote unquote bad habits? And basically, what are bad habits of COVID COVID-19 positive patients that may have rendered them vulnerable?
So maybe I'll defer to Dr. Gupta because he works with them in that ICU setting, but I would start by saying that it's probably not a lot of bad habits for COVID positive people. Most times, you know, I think that people are very responsible. I think there's a lot of fear right now, and the presumption is that anybody that coughs, I mean, you almost have to have a disclaimer whenever you cough or clear your throat.
I always scream out allergies as soon as I sneeze, all the time.
It's almost so necessary. People look at you, you know, but the concern is there, and I think that it raises that, you know, level, you know, awareness about what we're doing. With any disease, I feel like as time goes on and none of us see many people that we know with it, we start to get relaxed. Same thing with STDs, same thing. That's a regular thing that we notice about as trends, just being humans. I think that it's really important to constantly check ourselves. Like you were talking about, when I'm talking in this meeting, I have my hands folded just to avoid, you know, holding my chin. I sometimes do that. So I think that when we talk about bad habits, I don't think that they'll be specific to COVID-19 positive patients in the hospital. If they're in the hospital setting, I mean, all the bad habits are going to be based on the people around them. Those patients are generally pretty ill if they're hospitalized, and especially if they're intubated. So I would like to hear what Dr. Gupta has to say about that as well. Thanks.
Thanks, Dr. Gatson, and couldn't agree more with everything you just said. Just to add on, and I might tackle this a little differently. So individual level behaviors that the individual can control. I've noticed that places that have become hot zones here on the West Coast, like Yakima, in the middle of Washington State, we're seeing mask usage. I hate to bring this back to masks, of 1 in 3. And people not recognizing the importance of distancing, especially in indoor settings. I think a big problem in Florida, for example, data from Open Table showed that people started actually indoor dining without masking and without proper protocols in early May, and it had only shut down truly in the middle of April. And so those are individual level behaviors that, in the absence of clear state and federal leadership, we have some agency over. So obviously masking, avoiding indoor dining, avoiding indoor anything really in public to the extent possible are key. This is, but the other lens here, and I'll just briefly go here, Mia, you tell me if I'm rabbit holing, but part of this is just the injustice of who falls ill from COVID-19 and who doesn't. If you're affluent enough to escape to the Hamptons or Myrtle Beach and work in a tele-environment, you are by definition protected from some of the biggest individual level risk factors that we know exist for the virus and transmission, which is proximity to other people. Some people have the beauty of telework, others do not. And we know how that, the racial fault lines, the ethnic fault lines, the socioeconomic fault lines of, who is disproportionately not able to actually work in a tele environment. So that's one. 2, smoking, breathing in poor air, secondhand smoke, those individual level bad habits. I'm not saying there's necessarily a racial component to smoking, because I think that's a bad habit, at least in the United States, that is broadly shared across different demographic backgrounds. However, breathing in poor air, it definitely has racial overtones to it. We know that if you're in the inner urban city, your air quality is worse than if you live in more affluent neighborhoods. And we also know that if you're in rural counties, your air quality is worse. If you're breathing in poor air, by definition, you have lungs and a heart that is impacted. In just the last 2 years before COVID hit, there was a burgeoning literature on the impact of poor air quality on the human body, specifically the heart and the lungs. And so there are environmental risk factors, there are individual level behaviors like smoking that are tried and true that certainly impact a predisposition to a bad outcome from COVID-19. But part of that has a social justice component to it that we can talk about more if you'd like, Mia. But then of course, masking, distancing, it's such a complicated debate here. It's become politicized, but those are things that we have agency over.
I appreciate you offering that. I'm wondering, Dr. Gatson, if you can go ahead and extend any commentary on the justice lens as well.
Yeah, and I think that it's really very important to note that it's not just the social behavior, the things that, like you said, we can choose and choose not to do. Think about the patient that is smoking, and we know that smoking cigarettes, to quit smoking, smoking cessation basically is successful 1 in 8 tries. So that's somebody trying 8 separate times, and one time, you know, after all those tries, they'll be successful. This tells me that even if a person has an addiction and they're trying to quit, they still need access to certain resources to be able to go get that help. With healthcare facilities shutting down, even the smaller things that we don't think about, those counselors that would help with that, access to insurance that will basically keeping your job and having the insurance that would pay for something like a nicotine patch. You know, things like patients who use only public transportation to get to work. You know, those, when they close down public transportation, that limited not only the patient getting to the providers, but maybe some providers being there for their patients as well. So a lot of things happen in vulnerable populations that we, like you said, we look to blame, and we look to blame, you know, the person for becoming ill, for having a bad habit. But the truth is that, and someone made a comment, that you could be doing quite normal things, the things that were normal to your day and the things that were mandatory for you to live and, you know, survive. And those things, you know, put you at risk. Vulnerable patient populations are the ones, just as Dr. Gupta noted, that don't have the money and the ability to physically distance themselves from, you know, the disease. But I would argue also, as an immunologist, as a neuroimmunologist, that keeping yourself completely distant from any disease, you know, is also a risk, you know, for health. And I don't want to complicate things, but, you know, your immune system has to generate, it has to be challenged in order to remain strong. And so I would say for those people who are, you know, hiding out in the Hamptons, you know, it'd be interesting to see, you know, how they emerge.
I'm giggling, but I'll put that aside. I want us to stay with the idea of exploring vulnerabilities on a social level, but I also want us to talk about health, those who are health vulnerable. And you work with patients who have cancer. And so can you talk to us about how COVID-19 is impacting your patients and also the way that you approach care?
Yeah, thank you. I think it's a very hot topic. One of the major groups that I work with is called the COVID-19 Cancer Consortium, CCC19. So this is a group that has developed now what appears to be the largest, you know, registry of patients who are positive for COVID-19 and have a diagnosis of cancer. What we found using that data that was recently released, published in the Lancet journal, that globally the mortality for COVID-19 is 5%. That number increases to 16% when the patient has a diagnosis of cancer. Now, of course, there's more cancers that lend themselves, I would say, like a lung cancer and lymphomas. Those types of cancers, the patients have a higher rate of COVID and a higher rate of mortality. Breast cancer and thyroid cancer are on the lower end of that. The fact is that our cancer patient population really is at a significant specific risk. And when we think about the other things that compound that disparity, such as their vulnerabilities, where they live, the access to care, does it impact their employment, their financial ability to pay for the medications that they get? You know, and that spills over into now the responsibility by the providers to not create further disparities. One of the things that I've also been able to pick up from the research that's been done through the CCC19 is the idea that patients who are the exposure to different types of treatment, for example, and I'll just give one example, the remdesivir therapy that we heard a lot about. The CCC19 has released data that demonstrates, and although this data is still, you know, very small numbers and they really need to dig into it a little bit more, but on its face right now, non-Hispanic Blacks were less likely to get remdesivir despite the fact that this medication was shown to have a lower overall mortality than any of the other therapies. That was a significant find to me. And some of the reasons, that were attributed to that were, well, they were available. It's much more expensive. I should note that. And they were available only in small academic settings, maybe sometimes in clinical trials. The idea still that the fact that it exists, that we can calculate and find data to show that non-Hispanic Blacks were less likely to get that particular therapy, despite the fact that it's been shown in those situations to be more therapeutic.
And this is 2020, people. 20 years into the new millennia, and we're still having these conversations. Yeah, I appreciate you offering that. I want to also bring you in, Dr. Gupta, and talk to us about what does COVID-19 look like? And also, what does it feel like? I want us to ground ourselves in a very sensual conversation around COVID-19, because hopefully most of us will not contract it. But some of us either have or have loved ones who have had the virus, and hopefully everyone is doing okay. But some of us have lost loved ones to the virus. So absent of being able to experience it firsthand, what does it look like and what does it feel like?
Mia, thank you for that question. I have a different perspective, and it's probably, and it's colored just by what I've seen in the intensive care unit and what happens after. And so what I would say is we talk about in the public discourse, our public discourse is so devoid of reality, honestly, on what this looks like from the perspective of somebody critically ill on a ventilator with the virus. Public discourse talks about ICU beds, it talks about vaccines, hydroxychloroquine, and the sensationalism of headlines that often have no bearing or impact on improving people's lives who do get infected with this. The biggest gap I've noticed is, we're appropriately laser focused on flattening the curve, because if we don't flatten the curve, our EDs and our ICUs will get overwhelmed. And so that's important. But these patients, those that are lucky enough to get ICU level care who need it, they require minute to minute and hour to hour tender loving care from nurses and respiratory therapists. As a doc, I probably maybe spend, depending on where the patient is on their course, an hour to 2 hours in an ICU room. They'll spend 8 to 10 hours in full PPE, putting the patient on their back, flipping them on their belly, countless tubes, countless lines, multiple sedatives and paralytics just to keep them stable on a ventilator. It's not as simple as, let's get an ICU bed, let's get a ventilator, and we're good. There's a lot of TLC here that far exceeds anything I've ever seen when it comes to any other type of critical illness. That's one. Two, duration of stays to actually get somebody off a ventilator and out of the hospital usually are minimum between 30 and 40 days. So it's a long haul. And this is anybody, I've cared for individuals that are as young as 20 that have strokes in the setting of COVID-19, were previously healthy 48 hours prior, came in with a stroke. Because we know now there's this weird blood clotting that happens with the virus to those that are in their 80s and don't do as well. So this can affect us all. Lastly, what I'll note, and I wrote about this recently with a few colleagues, what happens once a patient leaves the ICU? It's actually pretty awful. There is no good outcome for a survivor that leaves the ICU after 45 days. There's no good outcome. The way our healthcare system and the support metrics we currently have, support systems that we have in place for somebody that's still requiring a tracheostomy. That means a breathing tube in their neck, because we remove the one from their mouth, but they still need a ventilator, so we hook it up to a tube that's more permanent in their neck, or at least semi-permanent. It's called a tracheostomy if you've heard of it or seen it. That requires long-term needs on the outpatient side in a nursing facility, home health needs potentially. And you know what the fact here is that the Senate is debating something called the HEROES Act, which would provide necessary support for home caregivers, for nursing facility workers, so that we could care for all these post-ICU survivors that have significant rehab needs, significant respiratory needs. It's not that they got discharged from the hospital, it's all good. No, there's this whole epidemic of what happens to all these individuals? And what happened to the caregivers that are supporting these individuals? We're not doing enough, not nearly enough in terms of providing them paid sick leave, making sure they have enough PPE. So that's what this looks like. This is a struggle. This is an acquisition of a chronic illness, essentially. Once you get over the acute phase, we're not doing enough to protect these patients and the caregivers that are providing for them in home health settings.
Dr. Gupta, if you're okay, we'd like to share a picture of you that you tweeted. Are you okay with us doing that?
Sure.
Okay, so Keiko is going to bring this picture up on the screen. And what I'd like to bring to everyone's attention is that in this picture, you're holding quite a large needle that you used on one of your patients. And I want you to please talk to us about what this is and how, help us to understand just how sick does a person have to be to get to this level of care.
So I probably shouldn't have been smiling in that photo. I should have.
Maybe you were laughing to keep from crying.
We're trying to keep a light attitude, just given everything that's happening. But so it's an ultrasound probe, and I'm about to go into a patient's room to insert a dialysis catheter. And the individual, when this photo was taken, was 30 years old, from Yakima, so the center of Washington. Don't know the circumstances by which this individual acquired COVID-19, but we know that it was in part driven by some of the factors that Dr. Gatson and I talked about: the inability to telework, all these realities that are essentially forced onto certain individuals, certain demographics of society, make it harder to actually avoid exposure to this virus. So this was us putting in a very large needle to support the kidneys of this particular patient, 30 years old. Kidneys were failing, and that's the other thing here. It's not just the lungs that get pneumonia; it's the heart has significant ill effects from COVID-19. Kidneys, one of the biggest bottlenecks to at least in the initial phase, especially in places like New York, was, do we have enough dialysis machines and dialysis nurses? Because all these patients have acute kidney injury. So we were putting in that catheter to support this patient. And not to get too graphic, but when you put in catheters like this, it's pools of blood spurting everywhere. And so I try to post things like that just to make it clear to the naysayers that this is real. This virus can affect us all. You can end up in the ICU regardless of your age.
And we see naysayers not just in, as you're walking down the street, they are in our long-term institutions. And it's scary to have to continuously make such graphic narrative available because some people just don't hear it when they need to hear it. Dr. Gatson, I'm hoping you can also help us to understand, and thank you for that, Dr. Gupta. That was really very vivid and useful to everyone's learning, I would imagine. And so I'm hoping, Dr. Gatson, you can expound on that. Tell us about some of the longer term damage sustained by your patients with cancer who also have a positive diagnosis of COVID.
Yeah, thank you for that. So sometimes I think that what we're dealing with is a combination of both the patient and their caregivers, their family members' concern about the disease, and the professional, the providers, their concern. Those two combined lead to situations where patients delay getting into the hospital. Say, for instance, they have cancer and we know that they have it, but they're due for their next infusion, chemotherapy infusion. They're so worried about it that they're calling and they're asking their provider, can I delay by about a month or 2 weeks just to get through this COVID thing? We don't know when it's going to end, and we don't know when there's a safe time, but we do know you have cancer, and we do know that you need this treatment. So there's a balance that's being toyed with now, and I think that the cancer, that CCC19 registry that I talked about, they're doing the work of capturing patients with their conditions, with their cancer, and we're figuring out what treatments are being offered. Where are there delays? Where are there disparities? So these patients delaying coming in, the providers pushing back and deferring certain treatments, not giving patient access to certain clinical trials because maybe a clinical trial would require that you're there once a week or once a month, and we're trying to physical distance. So those things complicate the patient's treatment. let's think about the situation where someone is ill and they have cancer, but cancer is not their problem. They all of a sudden have a heart attack. And heart attack, they're worried about COVID getting into the hospital. So they sit there and they delay, or stroke and they delay. So these people are now coming to care worse off than they would have had there not been this fear of, emerging and coming to our healthcare, centers. As physicians, I think we have a responsibility to minimize the contact where needed, but still encourage. And this is not what you see on the news a lot. You don't really get that encouragement to, when you have signs and symptoms of the regular things that are happening, not this you would think that COVID is happening 1 every 3 people, the way that the way that we see it online. And as regular people, you become afraid when you hear about it so much. But flu, heart attacks, strokes, the regular things that are normally happening to people are being deferred, and patients are not presenting when they need to. So I think we have a responsibility there. But to get directly to your question, some of the long-term effects that we're seeing, as Dr. Gupta mentioned, and I'm a neurologist as well, we understand that patients are having hypercoagulable states and being more likely to have a clot. And that is downstream effects of the immune system and inflammation. So we understand that these patients are at more risk. Now, if you say that in general people are more likely to have a stroke or more likely to clot, if they're positive for COVID or with these infectious inflammatory diseases, you have to now think about, what about those patients too that are already vulnerable and already susceptible due to their comorbid history of diabetes and renal or kidney failure and things like that. So we have a responsibility to, one, identify the people who are at highest risk, understand what the disease does to those patients. And that's why these registries and enrolling out, our communities getting on to these studies and trying to understand. It's observational. We're watching to see what happens. The registry helps us outline and identify these disparities and understanding what the downstream effect is. Someone commented that we talk so much about the mortality, of this disease and not so much about the morbidity. I've been taking some time to respond to some of these questions in the chat box. And it's true, most of what we see is the morbidity. I told you in the beginning that it's only a 5% global mortality, for the disease. So most of what we're dealing with are morbidities, and those things that complicate the disease, they're just complications and signs and symptoms of the disease, further complicate the lives of those who are most vulnerable. And I think that, we should spend a little bit more time talking about, how to mitigate some of those morbidities, and just forgetting, cut right through to the chase, get to why we have vulnerable populations, get to why we have people. There was a question someone asked me, then why is it that Black people, are at higher risk for the disease? That is not true. Technically, being Black is not bad for your health. What it is all of the same social injustices, inequities, inequalities, and disparities, all of those things that have lined up, including racism, policy, all of those things that have lined up to make it so that a particular group is more vulnerable, and the diseases that they get are more poorly treated, so that when we compound some new crisis or pandemic on it, the sort of wheel that's already loose on the cart starts to wobble again. It's a situation where the person who is most vulnerable in the beginning will suffer the greatest, when there's a new inequity or inequality or disparity or a new crisis.
No, and you're so right, and it's a common and disconcerting misconception that race is a biological factor, and that race as a quote unquote biological factor renders people who are Black more sick. That's not what it is. It really is structural racism and what power structures have been designed and crafted as a result of social policies over time, as a result of power distributions or poor distributive power across and aligning along racial lines, along class lines, and so on and so forth, and the confluence of the two and other oppressive systems as well, right? And so we have to be really mindful of that. And I encourage our audience, if you haven't yet taken a look or listened to, so since we're now in this shutdown phase in a lot of ways, or not yet returned to normal, a lot of congressional hearings have gone virtual. And the first one occurred with the Ways and Means Committee about a month and a half, 2 months ago at this point. And some of the questions, even from our policymakers, were very suggestive of them believing that race renders people sick. And thank goodness the witnesses were able to very clearly articulate, no, it's not race. It's the generational impact of structural racism. And it is not only okay, but imperative to call it what it is, so that policy can retrofit some of its impact to, to really redress a lot of the damage done by structurally racist policies, right? And institutions that have gleaned power from those policies, and moving forward to put things in place that, to your point, help all of us, irrespective of our race or ethnicity or salient identities, to live an optimal experience, to have an optimal living experience.
And I would say too, just so that nobody walks away with the wrong viewpoint here. We're all very intelligent people. We understand these issues that you just mentioned that deal with race and racism and policy. Those things are paramount to getting at the root of how to treat most of this. But we also have a responsibility, understanding and knowing now that the fact that we can articulate that these are some of the factors and these are the risk factors, we have a responsibility to ourselves and to our communities to do the basic things, washing your hands, just physical distancing, but we also have a responsibility to good health and eating better where we can. I understand that food insecurities are issues. Those are things that we can't readily change right away, but the things that we can do in our homes right now, if you have the ability to walk and move your limbs, getting up, becoming active, avoiding certain things of certain foods, putting down the cigarettes, putting down a lot of these things that we can potentially do for ourselves. We cannot rest and wait, for policies to change, because these policies were, put into place a very long time ago, and they support the people and benefit the people who continue those policies. So we have to work on both ends of the spectrum and not just, rest on the idea that policy has to change.
Agreed. It is definitely a both end attack. I want to stay with the idea of health vulnerable populations and talk more about, because you mentioned, we deal with things on a day-to-day basis that are even more ongoing and fatal than COVID is. So talk to us about those with, and this is for both of you, with asthma, or even the vulnerabilities of people who are pregnant, right? So what are some ways that they can protect themselves? And there's a question from the audience that explicitly says, what advice do you have for persons on chronic steroid therapy, for instance, for those who are treating themselves with asthma? Is use of certain medication in that case protective against long-term damage that is sustained from COVID? And then, what are the up-to-date council positions related to COVID risk level for women, for people who are pregnant?
Happy to take a stab there. So when it comes to asthma, there's actually some new research suggesting, this is in preprint, so it hasn't gone through rigorous analysis yet from peer reviewers, but that asthma actually, we would think it's a pre-existing lung condition that would predispose you to a worse outcome from something like COVID-19. I think the jury is out, just because in the way in which COVID-19 actually invades the cells in the lungs. And so we don't know specifically about asthma and COVID-19. There's some uncertainty about the degree to which there is risk. I think we should operate under a framework that any lung condition, any health condition that you might have, that you're battling, whether you're on chronic steroids for asthma, inhaled steroids rather, whether you have rheumatoid arthritis and are on a very strong immunosuppressive drug, that you are at risk and that you need to over-index on protective measures that Dr. Gatson and I had mentioned earlier on this. So take it to the nth degree. Have somebody else, if you can, in your household, do the grocery shopping to the extent that that is possible. We recognize this is challenging at the individual level, but it's those protective measures taken to the extreme for the time being. Quickly on pregnancy, because I know I want to give Dr. Gatson the last word here. What we know, again, this is all preprint literature, but pregnancy, I hate to use this terminology, but is considered, because pregnancy is a condition in which a woman is birthing a child and there's a human being growing within the body. It is considered in medical terminology an immunosuppressive or an immunocompromised like state, meaning you are more predisposed potentially to infections, to a worsened outcome with something like COVID-19. And there is some literature now, which we lacked 5 months ago, suggesting that. What does that functionally mean? That just means that, and I want to be careful in my terminology, but that you need to be extra cautious that if you're pregnant, about ensuring distancing. Again, if somebody else can go and do the shopping, great. Don't indoor dine ever right now. Make sure, always wear a mask if you have to go out. Those things should be taken to the nth degree, and you should over-index on safety. So same rules apply here, but there is some concern that that pregnancy might actually be might predispose to a worsened outcome from COVID-19 if you unfortunately become infected.
Yep.
And I know, I'm sorry, Dr. Gupta, I know you have a hard stop, so I just want to say thank you to you and for your time. And we look forward to having you again. And I'm going to pass the mic over again to Dr. Gatson.
Thank you, Dr. Gupta. Great talk working with you. But just like he said, I 100% agree. I don't have much to add aside from the fact that not just the mother is at risk, but it's also, we saw in the Zika virus situation where the unborn child is at specific risk. This is not brand new to us. We know that women who are pregnant and have rubella, or they're exposed to, German measles, as they call it, some of those children are born deaf. And, I think that we have to remember that there's a risk to the child as well as to the mom. And pregnant people have more frequent visitations to healthcare, settings. And so I think there's a lot to consider there. Yep. Thanks very much.
Absolutely. I really appreciate you both giving us such a wealth of information. This was also, it was not just enlightening for a lot of us. I think we had a good time here. This was a good flow. And I thank you for the work that you're doing. I hope that you're taking good care of yourself. I see you've got the bike and the treadmill in the back. So hopefully these are de-stressors for you. And I appreciate your accountability and also just your partnership, Dr. Gatson. And we look forward to having you again. And so I'll pass it back over to Brandon. Thank you all very much for tuning in, and please come back next week. We'll continue to have great conversation.
All right. Now, thank you all as usual for doing this. I noticed that just like you, Mia, the more we learn, the more we try to hold ourselves accountable, whether it's sitting on our hands, or I'm holding my hands like this constantly now. And then after last week's call, I always wash my wrist. So I'm hoping these, what our experts are educating us on is doing its part to sort of not only educate, but lessen the curve. Really appreciate you, Dr. Gatson, coming in and letting us know just how to be better and what this disease really looks like. That photo that you and Keiko found me of Dr. Gupta on there, that just really sort of emphasized the point of what this looks like when you are directly affected by this disease. So really appreciate everyone's thoughts. Everybody stay safe, stay clean, get the mask on correctly this week. And
we wear the cloth mask, or we wear the, I'm a bit, this is me giving a shout out to all the poets in the group. If you don't know the poem, We Wear the Mask, go look it up.
Okay. Well, that's our assignment.
Do the candle test.
There we go.
All right. Well, that's our assignment, and I look forward to seeing you all next week. Again, if you have any questions for the docs, they volunteered and put their email addresses in the chat box. So I'm going to let it stay up for just a couple more seconds in case you need to get it. And then we'll go ahead and say goodbye now. Have a good weekend, guys.